Good morning, everybody. I'm Howard Chansky. I'm the chair of the Department of Orthopedics and Sports Medicine at the University of Washington. And for our February 2024 grand rounds this morning, we're very fortunate to have Dr. Edie Shen, who's going to speak to us about preoperative optimization of the orthopedic surgical patient. Many of you know Dr. Shen, but for those who don't, she completed her internal medicine residency at Northwestern in 2003, and subsequent to that, joined the faculty at Harborview and UW-Medicine in 2006. She sees our patients in the preoperative medicine clinic. She also serves as the director of inpatient perioperative services at Harborview for the Department of Medicine. She's also the co-director, as I think many know, for the preoperative rodeo service. And she's also the service line head for the hospital medicine orthopedic service, which is a new service that we are very fortunate to have, and very fortunate to have Dr. Shen leading that. She is a distinguished fellow of perioperative medicine within the Society for Perioperative Assessment and Quality Improvement. So, Dr. Shen, thank you for joining us today. A really important topic.
Dr. Jansky, thank you so much for the invite and for allowing me to join you. I'm so grateful to be here today to have the opportunity to talk to your department about the preoperative optimization of the orthopedic surgery patient. I have no disclosures. First off, why does this matter to you as an orthopedic surgeon? I mean, I think we have many common goals. We really want to minimize or prevent avoidable medical complications. We want to decrease OR delays and cancellations for the good of our patients and for the good of our system. I think we all would like to improve patient outcomes and their satisfaction with our surgeries, decrease readmissions and length of stay, and really potentially even improve reimbursement. I won't talk a lot about this, but alternate payment models have been in play for several years for certain diagnoses. Of note, within our accountable care networks, I believe that we've applied bundled reimbursement to total joint arthroplasty and single level lumbar fusion. And as the graphic on the right indicates, we're really perhaps looking at a transition from fee for service to bundled payments where there is essentially one reimbursement for the entire episode of care. And of course, then that puts, I think, the onus on us as a system to really do what we can to minimize those readmissions, complications, and long length of stays. So the goals of the preoperative evaluation, I think when you consult your colleagues, whether they be in rodeo, geriatrics, medicine, and whether that be on the inpatient setting or the outpatient setting, the goals are similar. Really, we want to know, does this high-risk patient understand their medical risks enough? Are they informed enough to have truly informed consent? Are there any barriers to the OR? Is there any other testing that needs to be done to get to the patient to the OR in the timeline that the surgeon has prescribed? Are there any risk factors that still might be optimizable within the operative timeline? And in a really high-risk patient, of course, is there a need for a goals of care conversation? There are some comorbidities or symptoms that are common barriers to even time-sensitive OR, and certainly are particularly important in the elective setting. And so just to run through these quickly, obviously chest pain, shortness of breath, patients who look volume up, patients who have a history of significant valvular disease, patients who are end-stage renal or have an implantable cardiac device that might need to be interrogated or reprogrammed preoperatively. Patients who are actively wheezing or have severe lung disease requiring home oxygen are, of course, high risk. Patients with cirrhosis or ascites or those with pulmonary hypertension. And I guess I'm just here to say that if you get the sense that your patient has any of these things or you hear about that from the emergency room, we would really try to recommend upstream preoperative evaluation if it's not a crash. In terms of multidisciplinary care, I think that when we consult someone for a pre-op, we don't really like the term clear. We're not really clearing patients, but we're just trying to, of course, establish a safe path to the operating room. There is always risk, of course, in any elevated risk patient undergoing surgery. Things that are helpful to us as preoperative consultants of course, include anticipated blood loss, any surgery or injury-specific concerns you may have as a surgeon, the urgency of surgery, and if the patient needs optimization, then really what is the maximal allowable delay to still allow a good functional and surgical outcome? And what are the consequences of delaying OR beyond that window if we need to have a more involved conversation? So many surgeons that I've spoken with weren't aware that there is a toolkit for the American Academy of Orthopedic Surgeons. It's right on their website, and there's a toolkit that looks at preoperative risk factors. And so I thought I would talk about some of the major risk factors that the Academy emphasizes, which include anemia, nutrition, obesity, sleep apnea, and smoking. And then I've added a few other comorbidities of my own to discuss that I think are particularly impactful to the patient perioperatively. If you wish to access this, you can always Google Preoperative Risk Factor Toolkit or use this QR code on the right that I'll show a few times. Let's start off with nutrition. I think this is something that's really under-recognized, the presence of nutrition in surgical patients. So malnutrition is an independent risk factor for poor outcomes, even in an elective 1 or 2 level lumbar fusion. It really increases your all-cause mortality, your medical complications within 90 days. Your risk of infection and wound dehiscence doubles, and you have worsening functional outcomes. Once again, there are QR codes for many of these papers that are often in the bottom right. And in the patient who is an add-on in the inpatient setting, and I know the OR schedule is really hard to control, we really want to try to avoid persistent MPO states day after day whenever we can. In terms of nutrition labs that can be checked by you as an orthopedic surgeon for your elective surgeries, I think the ones that we primarily talk about are prealbumin, CRP is just part and parcel of this situation, but prealbumin, albumin, and total lymphocyte count. I think the caveat is that prealbumin, while we do talk about it a lot, CRP is synthesized at the expense of prealbumin in hyperinflammatory states. So if the patient is acutely ill or in a very inflammatory state, especially in the acute trauma setting, I think the prealbumin can be unreliable. But you can look at the albumin. And so many of these studies look at an albumin of 3.4 or less, because at that threshold, what we find is that the patient has a 7 times increase in major wound complications for a joint arthroplasty. And looking also at total lymphocyte count, that when it's less than 1,500, patients have a 5 times increased risk of wound complications. And so once again, if the CRP is normal, then the prealbumin can be relied upon to assess serially for response to a nutritional program. But our goals should really be to try to optimize that albumin to greater than 3.5 and a total lymphocyte count of greater than 1,500 within the perioperative period. So this is actually looking at the Academy's nutrition toolkit. These are specific laboratory parameters that indicate malnutrition or undernutrition. You can see they also added total protein, iron, serum transferrin, vitamin D level, calcium, and zinc. And so the Academy recommends that to replete deficiencies at least 2 weeks prior to surgery, of course, for elective surgery, especially vitamin D and protein supplementation. And they also state that collaborative efforts are encouraged. So whether that be primary care, medicine consultation, geriatrics, or a nutrition consult as an outpatient, and that one could use a nutritional screening checklist. On the other hand, let's look at the ERAS guidelines for the perioperative care and lumbar spinal fusion. They also recommend that we diagnose preoperative malnutrition. We can look at, of course, BMI. We can use, once again, a nutritional checklist, such as they specifically suggest the MNA, Mini Nutritional Assessment Tool, that I'll show you in a moment. They also point out that a low serum transferrin, less than 200, which is on the Academy's toolkit list, is associated with poor clinical outcomes in patients who are hospitalized, and that low lymphocyte count, the TLC of less than 1,500, has been associated with increased risk of surgical site infections, post-op complications as a whole, a longer length of stay, and 30-day readmission. So those are the ERAS guidelines. Let's take a look at the MNA, the Mini Nutritional Assessment short form, which was suggested by the ERAS guidelines. So it's pretty simple, has food intake declined for any reason over the last 3 months? Have you lost over 6.6 pounds in the last 3 months? And then we look at mobility, how immobile or immobile are you? Have you suffered acute illness or psychological stress in the past 3 months? And then there's this neuropsychological section that's interesting. Do you have mild or severe dementia or depression? And then, of course, we look at the BMI. And we add those up, and the lower the score is, of course, the more likely it is that the patient is malnourished. Once again, a QR code for that. Now, looking at the studies for why these recommendations are made and what we can do about it once we know someone is malnourished. So in looking at total joint arthroplasty and nutrition, what this article comments on is that hypoalbuminemia is the third most common modifiable risk factor for joint arthroplasty. It really comes in right after, I think, smoking and then using prescription opioids or being dependent on opioids. And their intervention in this study was pretty simple, an anti-inflammatory, high-protein diet. And really, they just deferred to the patient to try to follow this diet, but really it was a recommendation to minimize red meat, sugar, saturated fats, and carbs, and increase the good things, fish, nuts, seeds, vegetables. Aim for about 100 grams of protein per day. There was a mandatory pre-arthroplasty class that the patient had to attend, and they received handouts about nutrition. They were recommended to start that diet about a month pre-op. So 1 month pre-op, just start this anti-inflammatory diet. And what they found was that they aimed these interventions, of course, at patients who were felt to be malnourished. So those who had an albumin of less than 3.4. And there was a study hospital where those patients received this intervention and a control hospital. And of course, it's open to interpretation, but essentially during that time, what they found was that after receiving the nutritional intervention, these patients had a shorter hospital length of stay and readmission rates than patients at the control hospital. So this is an anti-inflammatory diet that began about a month prior to surgery as an outpatient. Looking at the ERAS guidelines, this actually looked at a Chinese study. It was a randomized controlled trial using MNM, which is a multimodal nutritional management protocol. Interestingly, this protocol had really nothing to do with the outpatient setting other than having the patient start a protein supplement just the night before lumbar surgery. Then they also had this protein supplement 6 hours or a little more than 6 hours prior to surgery before they had to begin their clear liquids only phase. They received a carb load 2 hours before, which I'll talk more about, but is also something that's recommended here as an ERAS measure. And post-operatively, so this is just protein packs and some carb loading, really in the immediate perioperative period and post-op. What they found was that there was a shorter length of stay, fewer electrolyte disturbances like hypokalemia, hyponatremia, and that patients actually had a higher post-op albumin level on post-op day 3 who received this very simple intervention. And so looking at this Chinese study from 2019, you can see that the length of stay actually went from 11.5 days to 9 days. That's pretty impressive with a significant p-value. Looking at another study, a prospective randomized controlled trial of nutrition within the setting of spine surgery, the intervention looked at, actually, they commented that the prevalence of malnutrition in orthopedic surgery patients is actually fairly high. So they estimated about 12 or 13% in joint arthroplasty and up to a third or more in spine patients, particularly in this study. And then when patients were malnourished, they really had a higher risk of complications, UTI, VTE, pneumonia, surgical site infection. And so this was a simple protein shake, BID, starting on the day of surgery intervention. So once again, not a pre-op, but more of a post-op intervention in the hospital. And they randomized patients to either get the shakes BID or just have a regular diet. On patients, of course, who had that low albumin, who were a little bit older, having elective spine. And so what they found was that there was a significant decrease in minor complications as well as wound healing complications in the patients who received their post-op protein supplementation. Lastly, this is just sort of an clinical expert recommendation from people who actually specialize in nutrition about an ideal diet around the time of surgery, orthopedic surgery, in order to preserve muscle strength, mass, and of course, good functional outcomes. So this is kind of a common sense approach. 7 to 10 days before, they just ask patients to eat protein and vegetable sources of protein, as you can see listed, lentils, quinoa, and the like. The night before surgery, the patient would have a well-rounded meal that would have at least 30 grams of protein. 6 hours before, they would take a protein supplement before they entered their clear liquids only period. And then 2 to 4 hours before, they would do their carb load, which is usually a clear supplement, with the addition of an essential amino acid supplement. I think that's the only thing that's sort of out of standard. And so their clinical expert opinion was that the ingestion of free-form amino acids, which some of you might be familiar with, because often people who lift or are trying to build muscle might take these. Ingestion of those supplements can promote a positive protein balance prior to surgery. And of course, that could be essential amino acids, branched chain amino acids, or just leucine. What they did find is that earlier post-op feeding does reduce our risk of infection, improved healing, and decreases length of stay. And so, of course, and I think I see this in practice all the time, our goal is solid food within 24 hours for the post-op patient. Just a quick plug about preoperative carb loading, which are part of the enhanced recovery guidelines. You probably have noticed that our pre-anesthesia clinic for elective surgeries does give patients I believe, a clear, something like a pre-op clear boost for the consumption of oral carbohydrates about 2 hours before the induction of anesthesia, before they enter their true NPO period. And the reason we do that is because that pre-op carb loading actually, of course, shortens that fasting period, which helps us to maintain protein balance, makes blood sugar control post-operatively a little bit easier. It enhances patient comfort and decreases their nausea, vomiting, and thirst and pain, and can lead to a shortened length of stay. So moving on to the next item in the toolkit, I just have a couple slides about obesity. The Academy essentially states, of course, that obesity poses significant perioperative issues for orthopedic surgery. I'm sure you all are familiar with that, including difficulty positioning, increased risk of infection and VTE, increasing the load across the implants that you're placing, predisposing the patient to premature failure of that surgical implant, and of course, worsening post-op pain and mobility. According to the obesity toolkit by the Academy, essentially the accepted threshold for elective safe surgery is a BMI of less than 40. And they recommend, of course, nutritional counseling and of course, lifestyle modifications where possible. I think in reading a couple of different articles, whether the preoperative approach to obese patients should differ from the general population is a matter of controversy, but it certainly may depend heavily upon surgery-specific concerns and the proposed surgical procedure. Smoking. Well, this is a big one. So looking at some of the data, I think we all know that smoking is bad, but just to clarify sort of some of the concerns that one might have, I looked at a randomized controlled trial of smoking cessation in patients with total hip and total knee. These are older studies because I don't think there are more recent studies. The canon is fairly well established. So this looked at 108 patients in, I believe, Denmark, and patients who are undergoing elective joint arthroplasty who smoked, of course, were randomized to intervention versus control. So control, they just got routine information, and control patients were offered a weekly visit with a smoking cessation nurse and free nicotine replacement supplies, which usually be a patch and maybe gum. And they actually had pretty good results. So in the intervention group, 60% of those patients quit, and another 23% cut their nicotine use in half. And in the control group, only 6% quit. There were really few pulmonary complications on each side for an elective joint surgery. And the overall complication was actually only 18% in those who had the intervention and 52% in the controls, which of course was a significant reduction in complications. And wound-related complications likewise decreased significantly, as well as bad cardiovascular outcomes and return to OR. But actually, when you look at the data, I thought this was really an interesting observation that people who were still smoking at the time of surgery versus cut their cigarettes in half, their outcomes were actually very similar for wound healing. But patients who stopped smoking completely had remarkably better outcomes. So it looks like cutting down on smoking doesn't help us as much as we'd hoped. We certainly just need these patients, to quit. So cotonine's half-life is about 16 to 19 hours. If you choose to implement in your practice, checking a urine cotinine level, then the patient would have to have smoking cessation for probably about a week. Some say 2 weeks, but probably about a week in order to be completely cleared. But we know nicotine is very deleterious in surgery and in wound healing because it causes vasoconstriction and, of course, like tissue hypoxia. That vasoconstriction is potentiated through the sympathetic nervous system and catecholamine release. It also inhibits the production of potent vasodilators. I thought this was a really interesting fact. So when a patient smokes one cigarette, their blood flow to their extremities is reduced by a quarter, 25% for about 90 minutes. So if that patient has 10 cigarettes a day and is spreading that out over the day, that patient is walking around with a significant burden of tissue ischemia and hypoxia. There are other factors, of course, that worsen that situation. Nicotine also impairs collagen synthesis because it affects vitamin C, which is a cofactor for that process. And I think it's safe to say, that it would be reasonable to consider vitamin C supplementation in many people, but especially those who still smoke. And that's something I think we don't do enough and is fairly a low harm intervention. And if you were hoping that e-cigarettes were more benign or safer, you should know that vaping liquid induced very similar magnitudes of vasoconstriction with or without nicotine. There's some additional mechanism that we do not yet understand. So if a patient tells you, I'm trying to quit, I'm using my vaping pen, and I'm not using nicotine, they're still going to experience perioperative vasoconstriction. In terms of smoking cessation, I would say that there's good evidence to show that if you stop smoking about 4 weeks prior to surgery, that you'll reduce the rates of wound complications. But there are prolonged effects. So really, it's best to quit smoking, of course, as far upstream as possible because fibroblast function takes several months to recover. Also, even ex-smokers are at increased risk of fractures for 10 years after quitting smoking. And with regards to non-union, 1/3 fewer smokers achieved union at 24 months compared with non-smokers, because of impaired osteoblastogenesis and chondrogenesis. So how do you as an orthopedic surgeon or your offices, clinics, faculty support patients in their efforts? I think, first of all, we should not assume that patients don't want to quit. Really, a vast majority of them want to quit. It's just really hard and they get discouraged. You've heard the data that it takes like 7.5 to 8 tries to quit completely. But that being said, patients are more motivated to stop smoking because their orthopedic surgeon tells them to than they are at any other time. People love to have surgery. Surgery is a wonderful carrot. So what we find is that smokers on their own, 70% really want to quit, half try each year, and a small minority are successful. But looking at a study of 10,000 spine patients, and I don't know exactly how they determined this high priority versus low priority, but when surgeons really placed a high priority on smoking cessation versus more of the perfunctory lip service, the smoking cessation rate almost doubled. And a recent survey within the Journal of the AAOS regarding the durability of smoking cessation for patients having elective lower extremity orthopedic surgery, almost 50% maintained their smoking cessation at 1 year postoperatively. And the ones who did relapse, about half of them said they didn't resume smoking until at least 3 months post-op, which is wonderful from, I assume, a bony healing and wound healing perspective. Anemia. Looking at preoperative anemia in orthopedic surgery, I think we're all familiar with the fact that it increases length of stay, prosthetic joint infection, surgical site infection, and death. That we think of people as being anemic with a hemoglobin of less than 12 or less than 13 in men, 12 in women. And using those markers or those thresholds, we would say that a quarter of patients who are having elective hip arthroplasty are anemic, and up to 50% of hip fracture patients. And when they looked at these patients who were over 65 who were anemic preoperatively, a third of them had a correctable nutrient deficiency, and another third had CKD or anemia of chronic disease, so something that maybe was potentially modifiable. I mean, of course, with CKD, you can give patients EPO if that's appropriate. And so looking at the preoperative anemia toolkit from the Academy, they recommend checking iron, transferrin, and a blood count, of course, in these patients. And so looking at an iron level, if it's less than 45, and of course, it's more complicated than this might imply the presence of iron deficiency. And so you might give the patient oral iron or have the PCP give that. A clinical pearl is that it really is just equally efficacious to give iron every other day rather than every day, better tolerated, better compliance, equivalent clinical outcomes. And then looking at transferrin, when transferrin is low, it really could be, the iron can be replete and there may be another cause like malnutrition or nutrient deficiency or the like. And then we would recommend, of course, referring these anemic patients to a primary care provider. This is way too much to cover within the scope of this talk, but just so you know, if there is a QR code at the bottom, that if your colleagues that you refer to need an algorithm to look at for how to treat preoperative anemia, it's available in this article from 2019. So how do we treat iron deficiency anemia? The modern formulations, despite what you probably learned in training, are actually very safe. It's very low risk of complications or anaphylaxis. And the more expensive modern formulations then can be given in just 1 to 2 outpatient infusions with a very low rate of reaction, as I said. And these are some of the formulations. I think we most commonly give ferrous gluconate, which has to be 3 to 5 doses in outpatient about every other day. And of course, that's something a primary care or outpatient perioperative physician can help you set up or help the patient set up. You should know that the hemoglobin levels do begin to improve within a week, but it takes about 3 to 4 weeks to normalize hemoglobin levels. And even as recently as about last month, I was consulted by one of the neurosurgeons and an inpatient to ask whether or not we should give IV iron. And because that effect really is delayed 1 to 2 weeks, I didn't think that was necessary. I think that patient was also infected, and there's always this concern of the risk of infection, and because iron is a growth factor for microbes or bacteria. That being said, when we give iron, we do decrease postoperative transfusion requirements, which is good, but there's no convincing evidence that we reduce the risk of death, length of stay, or infectious complications. And that's in studies with high levels of evidence. So anemia in the setting of injury, so the injured patient. So of course, this article points out that your initial hemoglobin can be spurious, right? Because when the patient receives volume resuscitation, their anemia may become more apparent, that one can expect a hemoglobin drop of about 2 grams with a subtrochanteric fracture. And they recommended that most patients with hip fractures who have an appropriate hemoglobin level have a repeat pre-op hemoglobin. I know that we worry about transfusion thresholds in patients with a history of cardiac disease, but what the studies have shown is that liberal transfusion strategies don't really decrease the risk of death. There was the FOCUS trial that looked at patients undergoing urgent surgical hip fracture repair. And they concluded it's reasonable not to transfuse these patients who have a hemoglobin that's, I assume, like a little bit less than 8 in the absence of symptoms of anemia. Sleep apnea. So sleep apnea is very prevalent and I think will be very relevant to your practice. It's something that is, I guess, of higher prevalence in patients who are undergoing total total joint arthroplasty. I guess because these patients maybe tend to be a little bit more obese on average. There's a projection that by 2030, there's going to be over 4 million elective hip or knee arthroplasties in the US alone. So this was a study that did a retrospective review of an administrative database of 400 hospitals looking at 500,000 elective joint patients. About 8% of them had coding for their stay as having sleep apnea. But it does affect up to about 25% of patients having elective surgery. And once again, is of higher incidence and prevalence in the joint arthroplasty population. So maybe up to 64% of total knee arthroplasty patients. Just for fun, I put a couple of options on the side. I mean, obviously we're all familiar with CPAP, and then you may also have seen that some patients have this hypoglossal nerve stimulator that's been implanted. It's called the Inspired device. It's actually very effective for sleep apnea. And just looking at this study, just in broad strokes, I would say that sleep apnea increases almost every single risk that these patients face. Serious complications are significantly amplified in the setting of sleep apnea. So that's why the Academy would recommend that your patients, that we consider having these patients undergo a sleep study. That's not always practical for a surgery that's already been scheduled or is time sensitive, but it should be considered. And then of course, the treatment options are not just CPAP, but also oral appliances, losing weight, lifestyle changes, not drinking, not smoking, and the like. Just a couple slides about osteoporosis. I am by no means an expert in this, but I thought this was interesting information. 1 out of 2, within a Caucasian population, 1 out of every 2 women will have an osteoporosis-related fracture. 1 in 5 of men within that population. We think there will be over 3 million fragility fractures yearly by 2025. And this is important. Up to 45% of patients who have hip fractures that you see in the hospital have had prior fractures. And if these patients had, following their previous fragility fracture, been treated appropriately for osteoporosis, we estimate we could reduce the burden of hip fractures by up to 22%. So I hope this is something we're doing. As it is, what the data finds is that only 5 to 30% of patients who are osteoporotic, who have hip fractures, actually get treated following their discharge. And so the studies show when the orthopedic surgeon brings up this possibility and the workup or, refers for treatment, the likelihood of treatment significantly increases. And so I think this is an important practice change if we're not yet doing this, because we certainly don't want to have failure to rescue these patients. And so if we were to start that workup, we would check, of course, calcium, vitamin D, low testosterone in men, of course, can be repleted, and then look for these secondary causes like thyrotoxicosis or hyperparathyroidism can contribute to osteoporosis. So consider these labs in geriatric patients who have fragility fractures, or all patients with fragility fractures. And also this article recommends consider this in patients scheduled to undergo elective arthroplasty and spine surgeries. Vitamin D levels, checking that is pretty high yield because 2/3 of joint arthroplasty patients have a low vitamin D level. And 97% of orthotrauma patients who weren't already told to take vitamin D or aren't taking it on their own are low in vitamin D. And we know that that is important from a bone healing perspective and may help us to decrease surgical site infection. The target concentration is greater than 30, and there are different ways of repleting it. Just a couple slides about perioperative hyperglycemia. It's interesting because the systems, the healthcare systems, and things like the BRE Collaborative, looking at bundled care for lumbar spine or a joint arthroplasty, focus a lot on A1C. And that's not unreasonable. An A1C of less than 8% is an average blood sugar of less than 183. That's not terrible. That's desirable, of course. And at Montlake and Harborview, my understanding is that we really recommend that for elective surgery from an anesthesia perspective, that the A1C be less than 8.5%. And that's an average blood sugar of almost 200. So that's pretty generous. When we actually look at perioperative glucose, it's really the average blood glucose levels around the time of surgery that are associated with mortality and poor outcomes. And an elevated A1C just by itself wasn't predictive of 30-day mortality after you control for the blood glucose. And so what that implies is that preoperative glucose management can neutralize the effect of an elevated A1C on post-op complications. Looking at this study out of Michigan, the Michigan Spine Surgery Improvement Collaborative Database, they looked at all elective lumbar spine surgeries in 2018 and 2019. About 9.6% of the almost 5,000 patients had diabetes. And I just said that A1C is not associated with higher mortality, but it is associated with, higher post-op complications overall, readmissions, a longer hospital stay, and really worse patient-reported outcomes. So they say, consider specialty consultation for optimization in a patient whose A1C is over 8 pre-op for spine. It's also, perioperative hyperglycemia is also a very strong risk factor for prosthetic joint infection. I believe at Montlake and Harborview, our acute care glucose goals are 100 to 180 for that reason. And what you should know is that if you have a patient who comes in, like an ortho trauma patient, and they're not a diabetic, in fact, their A1C comes back as like, 5 point something, but they're hyperglycemic, that patient has experienced significant stress hyperglycemia, and their outcomes are actually worse in the setting of the same level of hyperglycemia as a diabetic patient. Can't explain that completely. It must be just that they're really not accustomed to experiencing hyperglycemia. In the OR, our goals are 100 to 140. So your patients may come out of the OR for elective or non-elective surgery with an insulin infusion, and that can safely transition through the PACU to the floor, and upon which time the floor provider, should reach out to pharmacy or your friendly medicine colleagues and convert that patient to some kind of long-acting insulin, even in a patient who's not on insulin as an outpatient, but something like glargine based on pharmacy recs. To try to keep that patient as euglycemic as possible in the perioperative period. And this has been shown now over years to be a very safe process. So those were most of my medical pearls about preoperative optimization. As Dr. Chansky mentioned, we are beginning the HMS, stands for Hospital Medicine Service, Orthopaedics service line next week on February 14th. And I think another issue that I'd just like to discuss that can keep our patients as safe as possible is communication. And as this very simple graphic shows, it can be really clear to the person who's communicating and very unclear to the person who's receiving. And that particularly is the case when we communicate between departments and disciplines. And so now I will share with you an absolutely mortifying case that my department was involved in a few years ago. A 99-year-old woman who had a periprosthetic femur fracture. She was admitted overnight by the nocturnist to hospital medicine. She was full code by default, and upon admission was anemic, but also was a 99-year-old demented patient with some chronic medical issues. Orthopedics obtained consent via the DPOA. The patient was hemodynamically stable. The sign out from the overnight physician to the daytime hospital medicine doctor was, this patient's ready for OR and just waiting. We didn't know what time OR would be. Turns out the patient was slated for around 1 p.m. But the anesthesiologist, who was a senior, very experienced anesthesiologist, actually reached out preemptively to say, let's push this back. We need to clarify the patient's code status in a patient who, of course, at the age of 99 could have an adverse cardiac outcome or increased mortality perioperatively for the surgery that, of course, needed to be done if she wanted to walk again. That delayed things a bit, but the patient was felt to be DNR, DNI, and just, calmly sitting on the floor, a little bit delirious, waiting for OR. At that time, the patient was maybe a little bit tachycardic, but also was agitated in the setting of delirium. When the patient arrived in the pre-op area, she was hypotensive. Her hemoglobin had dropped to 6. There was a delay in the typing screen, and so she couldn't get blood right away. Within 40 minutes, of course, the anesthesiologist canceled her ORIF. And then there was unfortunately, a battle about whether the patient should go to TICU or MICU. She was And at 5:45 p.m., the patient, of course, was very hypotensive, went to the TICU and had a goals of care discussion that evening, transitioned to comfort care, and shortly thereafter died. So looking at potential opportunities using our toolkit, now I can't recall this patient's exact blood sugar, but even if she had ended up going to the OR as we had hoped with less acute blood loss anemia issues, if she had been preoperatively hyperglycemic, whether in the setting of diabetes or not, it would be completely appropriate to put her on an insulin infusion preoperatively. And your colleagues within rodeo or medicine can usually help with that, or geriatrics, of course. The patient in a previous admission was DNR and had AC, or sometimes patients have advanced care planning outpatient documents, like a POLST or whatnot, that imply that they're DNR living will. That would really emphasize to us that we needed to have a preoperative goals of care conversation rather than just sending the patient willy-nilly to the OR with her default full code banner at the age of 99. Of course, the patient suffered from acute blood loss anemia and hemorrhagic shock. She should have had a repeat hemoglobin on the floor, maybe on the morning after admission, and obviously been transfused preoperatively. She was bleeding excessively into, I guess, a thigh hematoma. And this patient was, unfortunately, low BMI and perhaps malnourished with recent failure to thrive, as many demented patients might have before a fall. We wouldn't have delayed surgery for nutrition, but I showed you some nutrition protocols that actually can be applied very effectively in the immediate pre-op and post-op setting, even for an acute care patient. And of course, we would consult nutrition. So I guess my point here about nutrition is I understand that our surgical colleagues who took excellent care of this patient tried to communicate, probably by saying periprosthetic fracture or distal femur fracture to us. I assume that as a surgeon, you've looked at the x-ray and you knew it looked like this on the left. Medicine, I know, often doesn't look at orthopedic x-rays. I know maybe that's shocking to y'all, but we'll have a full service of patients who are dying from lupus, cerebritis, and so there are often other competing priorities. And so if the medicine physicians didn't look at this very concerning x-ray on the left that would have given us a lot of information, it's possible that what they were thinking was closer to something on the right, which is, I don't know a lot about fractures. Maybe that's a terrible fracture, but that certainly looks like a non-displaced fracture that I assume wouldn't be terribly likely to bleed. So I think that when we communicate, once again, if you're concerned about bleeding, or you think that a blood count should be rechecked pre-op, or you think, I think just communicating that and not assuming that your colleagues always know that, especially now that medicine will be increasingly primary of some of these older patients, that's just an ask that we have. And I hope this is illustrative of why that might be helpful. I think this is my last slide. Increasingly, as my colleagues within orthopedics have pointed out, the community standard is for hospital medicine or medicine to take care of orthopedics patients. And I think as we begin this partnership at Harborview, and I'm sure our other institutions as well, of course, we just want to create a culture of strong interdisciplinary collaboration. I really think we have shared goals. Our goals are the same. We want the patient to do as well as possible, have the best functional outcomes, be happy with their surgery, we want to build good relationships and clear communication between departments. And as we do that, I hope, because there will be bumps, that we will try to presume good intent and approach one another with empathy. And lastly, our director of hospital medicine, Kim McDonald, who is very excited, as am I, about this orthopedic service at Harborview, has really tried to reframe the conversation by not saying we're going to be taking care of surgical patients. These are our patients. And I hope you'll approach with the same terminology as well. These are our patients, your patients as well. And we just want to put the patient in the center and take excellent care of them. Thank you so much for the opportunity to join you today.
Yeah, Dr. Shen, that was wonderful. Really appreciated it. And for those who haven't heard, there is a UW Medicine system-wide committee that is now looking at the issues around care for surgical patients. trying to assess what kind of balance we need between APPs and hospitalists, and trying to develop system-wide standards so our patients won't be getting different levels or styles of care at any of our hospitals. And so I'm really looking forward to see how that progresses. And there are some questions. First one was from Dr. Alan Greenwald. And Alan, you're welcome to speak up if you're able to. And Dr. Greenwald wanted to ask Dr. Shen about bone health optimization of patients for elective spine and joint replacement surgery. And I assume that's a follow-up question to some of the slides that Dr. Shen presented.
Yes,
Alan?
can you hear me? Yeah, I
Yep.
thought that was a great review, Dr. Shen. You know, you mentioned the risks of healing and infection in fracture patients, but in elective patients, there's a very high incidence of failure of spine surgery and infection in joints, and the spine surgeons know this pretty well. The patients have osteoporosis, and many of them over 65 do. What are your thoughts about maybe delaying surgery for somebody who has a very low T-score on a DEXA scan or has severe osteoporosis going into elective spine or joint replacement surgery? How would you manage that?
Yeah, thank you. That's an excellent question. I mean, I think that the struggle always is that I assume to start therapy for osteoporosis and really, to achieve any reasonable improvement in the patient's DEXA scores is something that probably takes, I'm sure y'all would know better than me, but months or longer. And so I think that's always a really difficult question. There's really no right answer. I mean, I think that perhaps one would say, or maybe the academy would say, that it's important to address these things as far upstream as possible. But because of the long delay, I think, in clinical response, as far as I know, and please, to all of you, feel free to chime in if I'm speaking incorrectly, that then it really comes down to sort of shared decision making and understanding the patient's values and the urgency of surgery from the patient's perspective, even if we consider it to be elective. But I will say that I personally don't usually optimize osteoporosis. I would also refer to like a bone health clinic, or we have our endocrine colleagues up at Montlake. I'm sorry, I don't have a better answer for that question, but it is a good one.
And Dr. Lack also has his hand up. Will?
Thanks. Thank you so much for your presentation. I wanted to just thank you for giving the example of the elderly patient with the femur fracture. And I have a personal, just very brief anecdote that I've seen that at multiple institutions. So it's not isolated to UW. The geriatric patient with a significant fracture that's associated with more bleeding than maybe is typically expected in an elderly population. And I've seen that exact story play out. And it can actually be very difficult to break, I think, the bias that exists both for surgeons and non-surgeons alike in treating a geriatric patient. And I've seen a patient who was hypotensive in the OR with bilateral lower extremity fractures and open fractures, but they had not had polysystem trauma, but had very extensive lower extremity injuries. And the anesthesia team just not able to understand that the patient wasn't in urosepsis, but they were a motor vehicle accident patient who was alert and oriented going into the OR and was in hypovolemic shock. And I just think there's a huge amount of bias there, and communication, as you stressed, is really important. And just going back to basics and saying what's driving this problem, and not just assuming that because it's this age or this patient with this comorbidities that it's a certain problem. It's usually the case. I really appreciate you bringing up that anecdote or that case. And then I wanted to just say that the comment you made, the points you made were really close to me, like the comment that you made about treating patients like they're just our patients together. And I'd say that happens within subspecialties or within specialties where surgeons or non-surgeons will say, for example, this is my call patient, it's not my patient. I've heard that before, and I just really, I just wanted to emphasize that your points today, including that, really struck home to me. Thank you.
Thank you so much, Dr. Lack. Yeah, I hope we can change the culture a little bit. That takes time, of course, but we're looking forward, of course, to working closely with your department.
Yeah, those are great points, Will. And I would add, I think it's under-recognized that the tissue injury that goes along with orthopedic injuries or orthopedic even elective surgery, it's not quite recognized. I think the impact that those have on patients, that they're essentially hyperthrombotic for prolonged periods of time. And I think sometimes our colleagues don't recognize that even though these aren't injuries to viscus or brain, they still really have a very, serious impact on our patients. The other thing I would say, and this is not for Dr. Shen, I think she's aware of this, but as orthopedics has become so technically focused in the 30 plus years since I was a resident, it's already nearly impossible to teach our residents everything about orthopedics that they need to know. And so their education has changed. And in their internship, whereas I think many of our more senior surgeons, we spent at least 6 months, if not longer, essentially taking care of critically ill patients during our internships. Internships now are really very orthopedic focused. And so I think more than ever, as we move forward, we really need to think about how to best care for our patients, emphasis on our patients, as you noted. Does anybody else have any other questions for Dr. Shen? Okay, well, we can finish a bit early. Dr. Shen, thank you. Thanks for all the care you provide for our patients, and thank you for this excellent grand rounds this morning. Really appreciate it.
Thank you so much for having me.
All right. All right. Have a good day, everybody. One last announcement. This is a UW medicine or UW policy, not a department policy. You have until 8:45 to register for your CME electronically. You have 1 hour before grand round starts to 1 hour after. Aaron posted some instructions in the chat box. And if you miss those or need them later, Planette can also help you with that. And Dr. Henley, I see, also posted a link to an AAOS article on perioperative care. All right, have a great day, everybody. Thank you.